Thank you everyone for joining this community network meeting for GHAPP, sponsored by Madrigal. This is just a great platform for us to connect and talk about a lot of the many changing issues in MASLD management, MASH management, and encourage you to really check out the website for other live recordings and also previously recorded topics because they're excellent. So today we're going to be talking about MASLD and MetALD. I am Sarah Dawkins. I'm a nurse practitioner. I work at Duke University Medical Center, and I work in general and transplant hepatology, and I'm a thought leader for the community network, the MASLD Community Network. So thank you for joining. If you could just use this QR code just to make sure you record your meeting. I think this will also be present at the end of the talk as well. So we'll hop on in with a patient case. So this is Ashley. She has been referred to your clinic for evaluation of an abdominal sonogram showing mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She's feeling great. She has no complaints. She is 52 years old. She is Caucasian female, and she has a BMI of 29.4. So her past medical history consists of PCOS, hypertension, and hyperlipidemia. She socially reports 2 glasses of wine per day. And on physical exam, she has a liver edge that's smooth and tender right upper quadrant area. There's no concern for portal hypertension on your exam. And she has listed her medications as amlodipine, atorvastatin, a multivitamin, and milk thistle. So her vital signs are listed to the left. She does have a BMI of 29.4, as we stated, a blood pressure of 140/78, so a bit high. And her labs show an AST greater than ALT elevation, so 55 AST, an ALT of 46, with an alkaline phosphatase of 140. Her bilirubin is 1.2. She does not have thrombocytopenia, so 210,000. Platelet count, she has a hemoglobin A1C of 5.9%, so in the prediabetes range, and a triglyceride of 185. So using these labs, we get a FIB-4 score using her liver test, her platelet count, and which is 2.01. So that's indeterminate, which would prompt further fibrosis assessment with a FibroScan or transient elastography. So she had a FibroScan score of 11.4, which puts her in this F3 fibrosis category. So she does have significant fibrosis, bridging fibrosis, and a CAPP score of 310. So a CAPP score of 310 is associated with severe steatosis. So this is a slide that just shows, that highlights the spectrum of steatotic liver disease. So ranging from the metabolic dysfunction-associated steatotic liver disease and MASH, or metabolic dysfunction-associated steatohepatitis, to alcohol-related liver disease as well. And then also, you always want to make sure you rule out alternative causes of steatosis that's seen in the liver, whether it be a drug-induced liver injury, monogenic diseases, or miscellaneous. So you want to make sure that you're not just assuming that steatotic liver disease is one of the like metabolic or alcohol related, and there is also cryptogenic steatotic liver disease. So you want to rule out Wilson's disease and Hep C and celiac disease, other things that can show steatosis on imaging. And then in the middle, so there's metabolic MASLD, there's alcohol-related liver disease, and in the middle there is MASLD with increased alcohol intake. So this is really going to be the bulk of our talk today and kind of how we diagnose and how we can manage these patients. And so I really like this figure here. It shows the MASLD predominant versus the alcohol predominant, and based on their weekly or their average daily alcohol intake is which way they kind of lean. Are they more alcohol predominant with a metabolic and alcohol-related liver disease, or do they lean more towards the metabolic steatotic liver disease? So what is one standard drink? So these are all the different types of alcohol, and it's 12 ounces of beer, 5 ounces of wine, 1.5 fluid ounces of a shot. And so each of these would equate to about 14 grams of alcohol in one standard drink. And I always tell people to remind them, when you're asking about alcohol with patients, make sure you include beer, because there are a lot of people who don't think that beer is alcohol. They really think that alcohol only constitutes like liquor. So I always ask my patients, what is your relationship like with beer, wine, or liquor? That way you get a good comprehensive history and you don't miss anything. So metabolic ALD is dual pathology. And so this is a really important slide, just showing the two different mechanisms for how inflammation happens within this process. So long story short, there's a lot of inflammation that happens that can lead to accelerated fibrosis and disease progression. And so the risk factors over to the left for metabolic related liver disease are insulin resistance, diabetes, obesity or visceral fat, unhealthy food or an unhealthy diet, sedentary lifestyle. Genetics certainly play a role here, and so do epigenetic factors. That with alcohol can lead to impaired lipid handling, which leads to oxidative and endoplasmic reticulum stress, leading to cell death. That, along with some of the disruptions in the intestinal microbiome, as listed above, really cause that inflammatory response, and that's what causes that collagen deposit and that progression of fibrosis and disease over time. So it's really it really gets driven by all of these factors. So what are the drivers of liver disease? This is a really great slide. It shows the risk estimations for decompensation for metabolic related steatotic liver disease, MetALD, and alcohol related liver disease, and according to their FibroScan score. So you can see that the risk for decompensation is much higher in the alcohol group. But so if a patient has really advanced stage fibrosis, their risk of decompensation for MASLD is 5 to 15%, and this is in 5 years. It's 10 to 30% in patients who have metabolic and alcohol-related liver disease. And then in alcohol-related liver disease, which at the very bottom you can see as alcohol goes up, that risk, that 5-year risk of decompensation really goes up. So it's so important as we're seeing our patients and evaluating them for metabolic-related liver disease that we understand their alcohol consumption, because as you can see, it can really just drive up the risk of hepatic decompensation and need for liver transplantation in the future. So this is just a really great study that showed the detection of alcohol use with biomarkers. The figure to the left shows the steatosis turning into steatohepatitis and cirrhosis. So essentially just the progression of that fibrosis and that disease progression with the alcohol use in addition to the metabolic risk factors. And so this study showed that that patients who have MASLD or NAFLD have about moderate to excessive alcohol consumption in 25 to 30% of the patients. And this was detected by hair testing, urine testing for alcohol, and also the Audit-C scoring system. So a lot of our patients are using alcohol, and we really need to understand how much alcohol they're using, and through biomarkers it's really helpful, because not everyone is always forthcoming with their alcohol use. So it's so important to kind of understand what their alcohol use is like. So when you're evaluating for steatotic liver disease, as we talked on a previous slide, always exclude any kind of alternative causes for steatosis or liver disease. So that's over on the right, medications, celiac disease. And then to the left, you see you want to evaluate for metabolic dysfunction. So do they have an elevated BMI? Do they have a fasting serum glucose over greater than or equal to 100? Do they have hypertension or elevated blood pressure readings? Do they have elevated triglycerides? And do they have low HDL? And then you also want to assess their alcohol use. So quantify in grams per week. You want to make sure you're asking about daily intake, and also if there's any history of binge drinking, any kind of socioeconomic consequences of alcohol use, and then prior history of hazardous drinkings. And then considering the PEth test if available, which we'll talk about in the next slide. If a patient over on the metabolic end only has hypertension or hypertriglyceridemia, so they don't have a lot of those other metabolic risk factors, you really want to consider using alcohol biomarkers, even if, especially if there's any undisclosed alcohol use, and consider PEth testing, because we'll talk about it in future slides. Alcohol use can cause these things in the absence of the other metabolic risk factors. So it's so important to understand what the patient is using as far as alcohol. So the PEth test, so our patient, we got a PEth test, and she had a PEth test of a 120, which is considered moderate to heavy alcohol consumption. So what is the PEth test? The PEth test is a great test that I use in my center very frequently, and this is used to detect alcohol. PEth actually is detected and it forms immediately after you ingest alcohol, and then it degrades very, 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 very slowly. So it makes it a really great biomarker for alcohol use. So you can have a patient, like you can see, that that drinks alcohol, they can quit drinking and come in with a negative like urine or a serum ethanol test, but the PEth test will be positive. And so it's really a great way to kind of understand how much alcohol people are drinking up to 5 weeks ago. So it's very helpful for our practice. And it's also not affected by sex or BMI, as evidenced on the figure on the right. So it's just a really great tool to use with a high specificity that helps us understand how much our alcohol our patients are using. So this was a great study that showed patients who are living with obesity or overweight exhibited 15.7% of them were actually at risk for having alcohol use for MetALD. So this just shows that we should be screening and talking to our patients about alcohol use in this cohort of patients. So our patient in her past medical history had PCOS, hypertension, and hyperlipidemia. So this is a great slide showing 32 randomized controlled trials showed 767 participants, and it shows that alcohol has a biphasic effect on blood pressure, meaning that the blood pressure actually decreases up to 12 hours after alcohol consumption, but then it increases 13 hours after. So greater than 13 hours after. So this patients who use alcohol in excess, so this was a dose dependent, it showed dose dependent in the study, showed that high alcohol use greater than 30 grams you can have people who have elevated blood pressures. So if you see a patient with just an elevated blood pressure, you really want to ask about their alcohol use. Additionally, alcohol can cause the triglycerides to be elevated. So in this study, it showed the water in the ethanol group, and it shows that after alcohol, triglycerides become elevated, whereas after water, they did not. So alcohol does cause the triglycerides to be elevated. So again, if you have a patient with not a lot of those other risk factors for metabolic-related liver disease, but they have those elevated triglycerides, you really want to understand what their alcohol consumption is like. So back to our case, our patient is drinking 2 glasses of wine per day, and with her PEth test, that would qualify as a MASLD predominant MetALD. So she is using alcohol, but she is on the more metabolic related spectrum. So if the PEth test was higher, then she would that would qualify over towards more the ALD predominant MetALD. So how do we treat our patients? So what are the current treatments that we have? Diet, exercise, and weight loss. So the Mediterranean diet is recommended. It's been extensively studied, and we have a printout that I give to my patients that just gives them a toolbox with recipes and just is a really great guide to kind of help them. That I don't have as much time in clinic, especially on the initial meeting. It's great to give patients something to take home either in their MyChart or their paper summary. Exercise, I recommend 150 minutes 3 times a week, mixture of resistance and cardiovascular exercise, and then gradual weight loss. I usually try to recommend about a 10% reduction in their weight to help with mobilizing fat out of the liver and reversal of fibrosis. And then, are they a candidate for resmetirom? So patients who tend to be more on the metabolic related side of MetALD, I would say, are candidates for resmetirom. And I think it's different in other practices, but if it's only alcohol-related liver disease and steatotic liver disease, I do not think that they're candidates for resmetirom. So for her, she has a FibroScan score that may make her a candidate for resmetirom. So I would definitely talk about that with her. What are your recommendations regarding alcohol use? Stop use completely. So I always kind of use motivational interviewing here around this and make sure they know the risks of ongoing alcohol use. So I definitely recommend they abstain, not 1 drink a month, not 1 drink a week. I say, especially with those liver tests and her FibroScan score, she should completely abstain. And of course, if you want to use an audit C score and to see like what does she need further resources or any kind of counseling or behavioral resources, you always want to offer those to your patients to help them be successful outside of clinic. And then, does she need HCC surveillance? Absolutely. She qualifies for F3 fibrosis. So I would definitely talk to her about her need for HCC screening with ultrasound, CT, or MRI every 6 to 12 months with AFP. So the ideal MetALD definition for clinical trials is based on objective biomarkers. So these biomarkers are so important to help overcome patients underreporting alcohol use. I mean, I see it every day in my clinic, and that's just for a multitude of reasons. I mean, there's stigma with alcohol, they feel shame. So using biomarkers is so important in patients who have steatotic liver disease. And then standardizing the assessment of recent alcohol use and of course, certify alcohol abstinence. So if you have a patient that's saying that they're not drinking, and then you can really use the PEth test to help guide there. I will say that sometimes it's not perfect, right? You know, if they quit drinking and you check the PEth test a month later, it still may have a little bit positive, but you can see that downtrend that it's headed in the right direction. And then ensure that drivers of liver disease are present. So making sure you're considering more than one cardiometabolic risk factor and ensuring the persistence of hypertension and hyperlipidemia after they stop alcohol use for those reasons we talked about before. So because alcohol can drive up the blood pressure and it can drive up the triglycerides. So making sure that's not just alcohol driving those metabolic factors. And then considering exposure to risk factors and fulfilling the criteria during the last 6 to 12 months. So what are the take-home messages? So the definition of MetALD is alcohol intake beyond 140 grams to 350 grams and 210 to 420 grams per week for men and women respectively. Using the biomarkers, so clinical criteria can underestimate MetALD. So making sure even if patients are denying alcohol use, but they have that blood pressure elevation or the triglycerides and not a lot of other risk factors, that PEth test can really help you. Ensuring that the drivers of liver disease are present, so reassessing metabolic dysfunction over time, and then considering adequate exposure to risk factors. So the criteria for clinical research should facilitate an objective MetALD diagnosis, allowing for comparisons among different sociocultural realities. So this is thank you so much for joining. This is a QR code for some of the other, it's really just for the community network. So you can see all the other podcasts and other meetings that have been previously recorded. It's great. Please check it out. And then if you wouldn't mind just scanning the QR code and completing a short survey based on your thoughts on today's presentation.